Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos. And if you're new to us, we're just super excited to have you here because we're having just some incredible conversations with real leaders that are changing the trajectory of care delivery. And if you happen to be sort of new to the show, we are really passionate about a few different areas. We're passionate about access, leadership, innovation adoption. If it's your first time tuning in, let me just take a quick step back, tell you what we're really trying to get done here. So the focus is on bringing real stories of innovation to life, not just things that you read online in a textbook. These are real things. These are real practitioners that are doing things on the front lines. And the aim is to highlight the leader, highlight the stuff that they're working on, the things that are going well, the things that aren't going so well, and give them a platform to be able to share their story with our community and ultimately with the world. So if you haven't had any chance to sort of check out any historical interviews, just wherever you are, if you're watching this, if you're listening to this, just hit the subscribe button now so that new episodes come directly to your inbox. So, look, there are leaders within our space that are doing some amazing things and ones that are managing complex, like a lot of complexity, and leaders that move through that complexity with clarity, with conviction, and an unwavering sense of purpose. And our next guest on the show is one of these leaders. Dr. Trisha Henwood is the Chief Clinical Officer for Jefferson Health. She's overseeing clinical operations and she's really building a blueprint for what quality care should actually look like. So through her leadership of Jefferson's nationally awarded OnPoint program, she's bringing structure, accountability, and humanity back into the way healthcare systems measure success. And her impact extends beyond just one health system, beyond geography. Dr. Henwood has really shaped emergency care systems around the globe, working alongside ministries of health, public hospitals, and universities to strengthen imaging, outbreak response, and community infrastructure in the places that are often overlooked. She led Jefferson's COVID-19 response through every stage of the pandemic, mobilizing testing and vaccination efforts for the city's most vulnerable neighborhoods. And today she's driving a major backed initiative that just sort of accelerate the adoption of evidence-based practices across health systems. So this episode it's about systems. It's about stewardship, the kind that takes time, humility, and the refusal to look away from the hard things. So, Dr. Henwood, welcome to the show. Good to see
Thank
you.
you.
How are you?
Glad to be here.
Yeah. So, just to start out a little lightly, I mean, before Jefferson, before sort of the global systems, what was the moment that made you say, this is my work. This is what I'm supposed to be doing?
Um, Actually, it goes all the way back to I started college pre-med, but I was very focused on my athletics at the time. And so I focused on rowing at that point in time instead of pre-med, but then ended up going back to do post-bac classes. And with that, post-bac pre-med classes, with that, I ended up doing some mobile medical work in the global context. I think in weighing, the considerations of going to medical school and taking that path. And I think that was really the context for me that brought things, the potential for impact and the potential for kind of scaled impact in clinical care delivery, in focusing on vulnerable populations, and then in thinking about where we can strengthen systems, whether they be local or global. So it kind of started a long time ago for me, and I think has continued to weave in an interesting way throughout my career.
Hmm. So what's like a moment, maybe one patient, one setting that you sort of still carry with you today?
That's a great question. I think one of the very impactful moments for me, I did work during the Ebola epidemic in West Africa. And I remember where we were delivering care in the field hospital setting was obviously very limited in the resources that we
Mhm.
had, which was quite challenging from the standpoint of resources that I was used to in my US healthcare setting. I'd done a lot of global work, so I was very used to a variety of resource or working in resource
Yeah.
limited settings. But obviously, the outcomes in that context and the really high mortality rate was quite a challenge. And I think one of the enlightening things was after I started to get out to some of the hospital facilities across the country, recognizing that the resources that they had in those settings were not actually dramatically different than the resources that we had in the field hospital that I was running with an international NGO. And so I think moments like that, where you think about where there's the ability to take the lessons that you're learning in the context and where you can think about, again, scaling impact across systems. So I think that was an area where I then kind of worked at the system level there in thinking about resources that could strengthen that healthcare ecosystem. And that's really been, I think, a weaving theme of my work, where it's sort of jumping into a particular problem or challenge, but then also zooming out into what's the bigger picture context, and where can we find those leverage points to improve care delivery with the resources that we have, or find ways to advocate for other resources to come to that context.
When you said you were working overseas, I just couldn't help but think sometimes you feel like having constrained resources is a challenge. Did you find that when you kind of came back to the States, when you were in a situation where the resources were constrained, that you could still innovate despite the constrained resources? Like, were there new levels that you could tap into just knowing how tough situations were overseas? Like, how do you sort of draw parallels to that?
Yeah, I mean, I think there was a lot of back and forth opportunities for me. I think working in very constrained resource settings, particularly from a diagnostic perspective, I think made me a much stronger clinician. So when I was back working at Brigham and Women's Hospital, and I had every type of diagnostic and some of the cutting edge care in the world, I realized still that that was something that helped me with my residents and trainees be a better teacher, right? Thinking about where I would push them, making a call on what was happening before the test was back and before you ordered the test, and thinking about, did you really need the test? So I think there was a resource stewardship that I carried forward from a lot of the context in very resource limited settings. And then at the same time, I think some of the innovation that happens in resource limited settings really has the ability to crosstalk to high resource settings, where, necessity being the mother of invention, where a lot of the work that I was doing from a standpoint of ultrasound training, sort of pushing the limits of where you would use ultrasound from a diagnostic perspective at the point of care, because there was not a CT scanner in that context, or there may have been one radiologist in the entire country at that point in time. So I think there was a lot of back and forth in terms of things that we learned and can learn from resource limited settings, and where you try to leverage the existing resources. And the same thing in terms of high resource settings, where you can be a better steward of resources and or become a better clinician by really thinking about the tests that you need, instead of just kind of ordering a battery of tests, which obviously drive up care, the cost of care as well.
So you're thinking about this decision matrix, and now that you're sort of teaching that, how do you build, I guess the lack of a better term, consistency across a massive health system, really without losing sight of sort of the local nuance?
Yeah. I think it's definitely a challenge, but I think it's something where we go back to those principles of evidence-based medicine, right? Gather the experts, gather the literature and the data in a certain area, decide what is the current best standard of care, evidence-based approach to a problem, and then thinking about how we scale that in the system.
Mm.
That may look like, I think one of the principles we try to consider is where we can have things as similar as possible and as different as necessary. So we might say that the order sets or some of the process work that we do in the electronic health record is something that we expect everyone to follow, because these are
Right.
the care guidelines and best practice, and how we can get that to permeate throughout the system. And then at the same time, we also recognize that the populations that we're serving are different in different contexts. The challenges those patients are facing may be different. And so we need to think about tailoring perhaps some of the transition of care work or the follow-up pathways, whether things might need to happen from a telehealth perspective versus in-health perspective, or who the right person is to help that patient navigate through either the current care setting or when they're transitioning care. So I think really a lot of the work that I do at the system level in leading a 32 hospital system is where can we infuse some of those pathways where we don't want people to deviate, or we need to understand why they're deviating because of, the
Hmm.
particular complexity of the patient, but also then recognizing where we need to have some of that local nuance coming into the approach that the local teams are deploying, the work that's being supported from a system level.
Mm. So you mean you're not just optimizing care, you're really reshaping what clinical excellence looks like. How do you how do you measure that in human terms?
I mean, I think we really focus on the outcomes. We focus on some of those leading indicator measures, right? If we're trying to change outcomes in a certain area, we're going to come up with different process metrics that we can say we think that, adhering to these pathways is going to help support the work. We look at the adherence to the pathways as we're going, and we make sure that's correlating with the outcomes that we're seeking. I think the important approach that we take an approach of resiliency engineering and thinking about the ability to make sure we're monitoring and we're adapting.
Resiliency engineering?
Yeah. Are you familiar with the concept?
Sure.
So resilience engineering is an area that's been described a lot in healthcare and in the quality space, but not having a lot of great concrete adoption or I think good examples. And so we really have worked that into the system at Jefferson, recognizing that there is, I think, an underappreciation of really the complex socio-technical environment that our
Yeah.
clinicians, our care teams, our patients and families are navigating, and that we need to think about where we can design that system for the outcomes, where we can think about those leading indicator approaches, and where we can get more proactive in creating a system that can respond to the challenges that we experience in healthcare. I mean, I think
Mm.
one of the good examples might be the IV fluid shortage that we recently had in terms of the Baxter plant impact from the significant hurricane hitting North Carolina.
Yeah.
With that, the ability for the system to kind of respond and adapt, right? How do we pull together the right people to make sure that we're being incredible stewards of the resources that we have the inflow considerations, that we can come up with the pathways to monitor the supply that we have, the burn rate of certain things in certain areas, clinically appropriate alternatives, and the ability to move through that. So we didn't need to cancel procedures and things like that. We
Mm.
were able to continue to deliver the expected standard of care that we have. And so I think that's one example of where you see resilience in the system and what we've tried to create in terms of interdisciplinary teams that work together on a daily basis. But then
Yeah.
also they can come together very quickly when there's a disturbance in the system, which unfortunately in healthcare, particularly in US healthcare, we're experiencing with a more regular cadence, I think, ever since COVID. So I believe, and I think our approach from a system standpoint is to try to create those factors, both in how we do the everyday work, but then how we can essentially leverage those processes that we have and those teams that we have. We think about people, process, technology. Where can we leverage all of those in the times of challenge to try to have the system move through and sort of recover, and that being essentially a measure of resilience of the system itself.
Do you find that the diversification of the team, the different disciplines that are involved, does that help build the resilience, or do people kind of view their own disciplines in their own little silo, or is that more of a cultural thing where you say, look, we're all kind of rowing together in the same direction? I know you're a rower, so pun
Yeah.
intended, but
Thank you. Thank you. Yeah, no, I think the building of those cross-functional teams, I think is so critical, and the ability for teams to work together and or to speak each other's languages
yeah,
is important in essentially the times of everyday operations, as well as in some of those challenges from a standpoint of, that was really a disaster that U.S. healthcare faced in working through that shortage over that couple of month period. I think those small dedicated teams that have really different lenses coming from different teams are critical. I was reading, Tom Lee has a recent book out about social capital, right? And he talks about bridging connections and bonding connections. And actually, one of the teams that I lead, I believe they sort of drive the bridging and the bonding connections because they have deep relationships in our IS&T teams, in our nursing teams
Yeah.
and in our quality teams. And so that helps make sure that those teams are coming together and most effective with, all of the other members of the teams that kind of come out from there.
Hmm.
Um, I think that that's something that healthcare needs to be focused more on, especially as we think about the incorporation of technology and the potential for technology. But if we have IS&T in a silo over here, and we have quality in a silo over here, we have nursing in a silo over here, we're really not going to get as far as fast as we could if everyone is, coming together to function as one team. Whether it's solving an acute challenge or thinking about kind of the priority work that we're looking to roll out throughout the year.
I love what you talked about, social capital. I call it relationship equity. And it's kind of like
Hmm.
human beings they work a lot like a bank account. When you open
Yeah.
it up, you kind of have to deposit into it. And sometimes you make withdrawals. Oftentimes, what you do, unbeknownst to many, is you transfer that relationship equity to someone else. And it sounds like with this interdisciplinary team, that's what you guys are doing.
Yeah.
You're transferring it. So now all of a sudden you're not starting from zero. There's a balance there, and you can get work done better, faster, more efficiently, and at higher scale.
Yeah, I mean, certainly, I think the partnership that I have in particular, for example, not only with our chief physician executive and our chief nurse, but also with our CIO and the work that we do with IS&T together, I think is very unique. But we really see that the EHR ends up being essentially like the backbone, right, for how the system is functioning. And so we need to think about how closely we can partner in
Mhm.
designing something that wasn't necessarily designed for quality and safety outcomes, and how we can design or redesign that to get where we need to go and to support our clinicians, right? We're really focused on how we can uh, work towards those outcomes in concert with our patient and families, but how can we make it easier for our clinicians to do the right thing? When a lot of times they just can get more and more piled on in terms of the expectation from the human capacity that's not really matched with
Right.
reality.
I just think about because, when as a leader, when you're the one that, folks look to for direction on your team, especially in chaos, and you've been through it, you've
Yeah.
been through a ton. What does composure look like behind the scenes? Like, what does it really look like behind the scenes?
I'm laughing because on my wall I have the Viktor Frankl quote, between stimulus and response, there is a space, and that space is our power to choose our response. In our response lies
Yes.
our growth and our freedom, right? I think really that ability to respond versus react, I think it comes down to that for me in the standpoint of, if I'm leading a crisis response, like many of which I've led in the US and in a global context, versus in the everyday interactions or HR challenges or emails that people shouldn't have sent, for example. I think it just looks like that ability to take a beat and make sure that you're responding instead of reacting, and setting that example for the teams. And, I think working through that organizational culture in terms of something may have happened, but we're going to look at how we're going to handle it, look at how we're going to learn from it, look at how we're going to move through it. Instead of just reacting to the event itself. So I think that that is also part of the consideration from in bringing in resiliency engineering principles, looking at those opportunities to learn from challenges and to learn from
Yeah.
success, both, and where we can bring that forward. But I think it really comes down to some of it comes from my parenting. I think I was just saying to a friend over the weekend, my 7-year old deeply feeling child has certainly made me a better leader, because I have to, continually from that standpoint thinking about responding and not reacting. And I think it's a pretty similar thing in the context from a leadership standpoint and or from a clinical standpoint, when times are challenging or even in the midst of daily operations.
That we could riff on that for days.
Yeah.
Um, Responding versus reacting versus responding. And my, I've just seen the good with when it comes to responding and being thoughtful. Like you said, Viktor Frankl, by the way, that was an amazing book. Really, really
Yeah.
crazy. Um, but yeah, versus just reacting raw, hard. Like that doesn't really do any good. So let's just say this is a fun question. Maybe you're stuck in traffic on I-95, with a new clinical leader sitting passenger side. raw talent, but they're completely overwhelmed, and you've got 15 minutes before things clear up. What's the story or even like the truth that you're going to give to them that they have to hold on to?
Um, I think in addition to the sort of respond versus react, the relationship focus, right? The idea that those little interactions, right? If you're reacting in some minor interaction, that ends up having consequences later down the road, or someone that you might not think you're going to be
Yeah.
interacting with a lot across the system, for example, or maybe they're from another system, but it always comes around. So I think it's again, it's similar in a professional context and a personal context in terms of thinking about how you would want to manage that situation and thinking about the idea that assuming good intent for how you're interacting with people,
Yeah.
and or moving with grace, right? Depending on what side of the situation that you're in, I think is a really important thing. So for me, it comes down to, I think, getting the work done in complex systems is about teamwork and it's about relationships, right? Like the humans are still going to be the ones that are helping execute at the end of the day, regardless of technology. So really focusing on that relationship building, not from a standpoint of just pure networking, right? But just that
Right.
human interaction, and how important that is to how you are perceived, how you can continue to work with those people, their teammates, and kind of how it moves across the system. So I think thinking about that relational piece and how much that drives the ability to collaborate and how much that, leads to the outcomes that we want ultimately for, our patients or our community or the system, depending on your context.
Is that overlooked sometimes? You feel like as a leader early on, had someone told you that, you would have been, things would have, obviously you're in a great seat now,
Yeah,
but do you feel like
I do. I
that's a
mean, I
missing
think I
element?
was very lucky early in my career. I was in a context where I wanted to switch contexts, and one of my mentors said, "Everyone will always remember everything about you from the second they knew you were leaving." Right. So how I went out in that context was sort of
Mhm.
more important than the impact that I had ahead of that. And I think that type of advice, and that's something that I've shared with many others, right? Because usually if you're departing somewhere, it's things are not going as you expected, usually a challenging context, but thinking about how the world is a small place and how you may, cross paths with so many people in the future, and or how their respect for you is indicated by if you kind of burn the bridge on the way out versus if you think about, I'm going to try to continue to support my
Yeah.
teammates until I've departed. And I think that at a very early point in my career, getting that type of advice, I think led me to think about how important those relational pieces are. And many times since then, like over many, many years, I've had colleagues that said something to me about how I managed that situation, right? From, different places across the country. And so I think that is just, I think, a testament to the idea that if you're really trying to support the team to the end, and or sort of move with grace through those situations, that it really does make, I think, a big difference in the long run.
So there's been a lot of golden nuggets from this conversation. That's the second golden nugget. And so for me, that takeaway was, look, last impressions are lasting impressions.
Yes, exactly.
Uh, so you've just kind of going back, you mentioned something about building bridges. So I'm thinking about sort of the partnerships that you've been able to build across, health ministries, universities, and sort of even public health systems. What do you think the key to building uh, durable sort of coalitions are, especially during like real fragile environments,
Mhm.
highly sensitive times? What are some of those keys?
Um, I think it comes down to understanding, right? If you had to think about one word, I think a lot of the work that I did in the global context and helping to build different types of systems always started with a needs assessment in literally understanding, like, how does your system function and what do you think you need in your system, right, to
Mm.
get where you want to go, or to improve outcomes or advance some of the clinical or care systems. So I think really understanding, not parachuting in with like, here's the plan and we're going to implement. I've almost never seen that work. because I think things need to be tailored to the context in order to have the uptake and in order to have the sustainability. So, I think that was how I started much of the global work that I was doing, or some of the health system strengthening internationally. I think in my current context, it's the exact same thing. When we think about an area where there's an opportunity for improvement and we're thinking about priority focus for the coming year and or years from there, I have a team that's just spending weeks and weeks essentially falling in love with the problem, understanding
Mm.
what are all the different teams that connect to this. Not just, you might take a topic like heart failure, for example, and you say like, oh, we need to figure out what's going on with the heart failure doctors. Like, no, we need to figure out what's going on with the emergency medicine physicians, the hospitalists, the case managers, hospice, pharmacy, their health related social needs, the ability to get the meds, the community impact team, really all of those pieces that go into what's happening for our heart failure patients. So I think taking that approach of understanding what is the ecosystem as you're going in to try to address something or to rebuild something or to design something from a system standpoint makes all the difference, because then you understand not only the existing processes and or challenges, but you understand who the players are, or come to kind of chase those threads of all the different players that I think traditionally in healthcare improvement don't always get brought to the table. There's a smaller, maybe central team in quality, right, that are coming up with the plan and pushing it out. And then, it has some of these rough patches because those other teams weren't at the table at the beginning in the design
Right,
process,
right.
with their voice and or their stakeholder perspective represented. And I think the same goes for patients and families, how we can bring them in at the beginning of the process to make sure that we are working in concert with them, right? And not designing something that they will be the user for, that's not going to actually work from, or be what they're looking for.
How much time do you give your team, and do you spend on you call falling in love with the problem? Like, is that like in a sprint from a design standpoint? Like, how do you give it like, hey, 2 weeks, dig in, find all the
I
pieces that we
mean,
need
it's
to know?
a
Like, what does that look like?
we for our biggest priority efforts, and I think part of the, again, difference of my team, we recognize that there are hundreds of metrics from a quality standpoint that we are held to, and we need to keep focus. We need to keep focus on as many of those as we can, or those that we think are clinically relevant. But at the same time, we can't be great at 150 things at the same time, or we could try to be great at them, but we can't try to improve them all from
Yeah.
where they are, right? So we need to focus. So really the focus of my team is on prioritization. What are those things that are going to be the hardest hitting for us to focus on? And then how are we going to, work on that improvement? So with that, we usually take around 5 topics per year that are the focus for things that we're going to work to drive at the system level, across the entire system, set targets at the system level, that will work in coordination with all the local teams. But it's a several week to months process in the planning stages, right? And then
Do,
there's always a
does the
process.
prioritization swap? Like, say, hey, these are the five. Can five go to two, two go to five? Like, do they
We
move
keep
around?
we have those as domain priorities in quality, safety,
Got it.
experience, health equity, and pop health. So we essentially, in those domains, we pick like what's the top priority in this area, and
Got
that's
it.
what we focus
Got it.
on. The local teams will have areas that are their focus as well. So at a hospital level, if there's more of an opportunity in a certain area, they'll have a couple that are their hospital level focus for improvement. The system level ones are where we see that there's kind of an across the board opportunity, or more of the sense of we need to redesign how this system is working together, right? We need to redesign how the population health team is working with the medical group, is working with the hospital and case management groups. And so we take those types of things where we need to think about how we create different systems of
Mm.
care oftentimes, and or different systems for how we're addressing things like falls and how that interfaces in all the different ways. So depending on the priority, it's a couple week to multi-month process, honestly, because we want to design for sustainability. So we're not trying to do like a short sprint and fix one piece. We're trying to fix an aspect of the system. And it takes us several months of the work, often, working with our HR designers and analysts to think about how we can pull some of those levers, and then how we start rolling that work out and very closely monitor how that's working. If we need to kind of iterate or change how our clinicians
Hmm.
are interacting with that or our patients, depending on what the case may be, and then iterating from there and watching that closely. So it does take us several months to start seeing often to see the improvement on the efforts, but
Right.
usually then we bring it home strong and work towards sustainability as the most important thing, that we're taking those challenges and helping to redesign those aspects of the system, and then make sure that we can kind of hold that at steady state, because we didn't just ask our people to focus on it. We changed the system and how it's going to support our people in focusing on these areas.
So then what does um, implementation ready innovation look like to you? And how do you know when something's actually ready to scale? Because I mean, 32 hospitals, so a small change isn't small,
Mhm.
especially at that scale.
That's a great question. And I think it does depend on the topic. Some things we want to do more tests of change, and some things, if it's, for example, some of our order sets that we are like, this is what we believe should be being prescribed based on the latest evidence, and we want to roll that out across the board. And then we're kind of monitoring for the engagement
Yeah.
versus other areas where we might say, okay, this is something that we're not, sure how it's going to play out in the system, and we're going to pilot it at one or two of our hospitals and see how that's going over a period of time, and then scale from there. So it depends on, I think, the nature of the activity. If it's something that we believe is the path, and it's a matter of getting the engagement and how that's going to take us, then we will kind of scale broadly and continue to focus on engagement. If it's an area where we're not sure if it's going to get the results that we are looking for, then we will pilot, look at the impact. Those are usually things that are more related to patient outcomes, seeing if it's having the outcome, and then we kind of scale up from there.
Hmm.
So
I
very
really like
context
that.
specific, I would say, depending on what we're working on and how much of the interface is with our which aspects of the care team. Are we working across all the members of the care team? Are we working with our nursing colleagues, and where we need to kind of focusing on something that's more nurse sensitive? Are we working on something that's very specific to our physicians and APCs, and how we might need to think about how we're engaging there, supporting documentation? So it's really, I would say, tailored to the audience and then the type of improvement or outcome that we're focused on.
Hmm. So your comments sparked something. We're going to do a little experiment. Do you mind if we just do a
All
little
right,
experiment
let's
here?
go.
I'm going to call this a little wild card moment.
Okay.
And I want you to say whether something is overrated or underrated.
Okay.
Um, strategic planning retreats, overrated or underrated?
What duration? What's the timeline? 1 year,
20.
5 year?
I mean, let's just say a 1 year strategic planning
Um,
retreat.
I think 1 year relevant. I mean, part of this is sort of my lens of healthcare right now and today, right? I think a 1 year time horizon, like we got a plan for what we anticipate to come or where we're going to focus. The 5 years, I think, are pretty challenging in terms of how dynamic the landscape is, right? And how much
Yeah.
time you're putting into that versus thinking about where can we integrate transformation now, and then, where are we getting ourselves in a year or two? So, and also it depends on if it's something that is it, a quality improvement effort or a financial transformation effort. I think that those are different, right? Do we need to work on diversifying our revenue streams? That might be a good 5 year, right? If we're thinking about operational priorities, I think the short term is where I would keep the focus based on all of the changes that we continue to
Yeah.
see in the healthcare landscape at sort of all levels.
Hmm. What about overrated or underrated? Performance dashboards.
Um, I am a fan of dashboards, but only if they're providing insights and not just data, right?
Okay.
So I think that dashboards are no good if people aren't interfacing with them. I think if you have dashboards that people interface with, everyone knows that's where they go to get the source of truth, and that is where things are performing in real time, then I think it's relevant. But a million dashboards that no one engages with, no bueno.
You know what I'm really enjoying is the context that you give with your answer. It's great.
Well, I mean, it's very tough because I'm a fan of certain types of dashboards. I guess
Yes.
I should just say that.
Yes. How about just random leadership books? Overrated or
Yes.
underrated?
I think I think underrated, actually. I think they can be a context for that sort of like asynchronous mentorship and learning from different disciplines. So I'm a big fan of that. I think that healthcare um, is really, very, very complex. And so we sort of keep our head down in the healthcare ecosystem. But what we can learn from tech, um, business, other disciplines, safety science, and bring into healthcare, I think
Hmm.
that's priceless. And I feel like that's a lot of the um, innovation that we have a focus on. It's not necessarily brand new concepts, it's just things that have not been well applied in the healthcare environment.
Hmm. Well, you mentioned something, so then switching gears again. How about your mentorship? So how has your mentorship evolved, in the last few years? And then what do you look for now that, for
Mhm.
things that maybe you haven't looked for before as it pertains to that?
Yeah, I mean, I think I was very lucky. I've been very lucky throughout my career from a mentorship perspective, especially in the early days. I went to a training program where it was, I think, incumbent upon the faculty to be mentoring and just kind of very much part of their day-to-day activities, and that was
Hmm.
hugely impactful in the work I was able to do, even through residency and right out of training. And the sort of the early start for a lot of the work that I was doing in the global context was because I was able to do that with the support of my mentors as I was going along in residency instead of kind of waiting to build my career later. So that was, I think, a huge impact for me. And then as I continued to move along in my journey in emergency medicine and global health, I think I often needed to seek, again, those interdisciplinary mentors because I was on a pathway towards, applying for K, and there weren't the right types of mentors in my field. And so I needed to go
Yeah.
to different mentors in different fields, even at different institutions, and work with them. And so I think that was really helpful, again, in that kind of broad perspective. For the work that I'm doing now, I think obviously the leaders that I'm working with, my role as it is currently is fairly unique. And so I think there aren't as many blueprints or sort of playbooks for what the role is and how it
Yeah.
evolves. But I think I'm really, I think creating that a little bit more for what it is in the current context, and particularly in this time of transformation for healthcare, and where we can think about leveraging that tech stack to help support operations, to help support quality outcomes, to help support safety, and working that through. So I would say, now I'm in the environment of a lot of the working with my peers a lot, and thinking about how we can think about things differently. And so I think it's been at some point that hierarchical mentorship, and then at other times, now a little bit more of the context of the peer mentorship and where we can think about continuing to move healthcare.
This has been I've loved this conversation personally. I think it's great. What's the best way for people to learn about Jefferson, to learn about your work? I mean, I feel like you and your team are doing just some incredible things, Dr. Henwood. What's the best way for people to do that?
I mean, people can feel free to reach out. We are working further. We're getting, I think, interest, and have some organizations we're working with from a consulting standpoint. We obviously have found a lot of success with this approach, and really think that it's a way to, help improve outcomes and operations in clinical care settings, especially at the system level. So I think people can feel free to reach out to me. I can make sure you have my email, and happy to have conversations and how we can be supportive. I think there's a lot here and a lot of opportunity when otherwise in healthcare, I think we see a lot of current challenges in the landscape and/or a lot of the financial headwinds that everyone's facing, but also thinking about how we do the work differently and how we can have our teams do the work differently as we bring more technology into support, not obviating their work, but where we can have our humans kind of focused on their highest level work and the efficiency that they can deliver, and that unique perspective versus where we can take some of those mundane tasks and think about where technology can support, them and help us prioritize more.
This has been a fascinating discussion. If you have tuned in and you've enjoyed this, hopefully as much as me, if not more, would you mind just sharing it? Liking it, commenting it, letting us know how you felt about it. So, for those, thank you, Dr. Henwood. It's been amazing,
Yeah,
and the
thank you for
door is
having
always
me.
open. Yeah, always open. Having you come back on. Maybe we could jam out again about some other things, but we'll probably have to do that off camera.
Sounds good.
All right. Thank you so much.
All right.